Welcome back to another Oncology for the Inquisitive Mind, ASCO edition featuring Michael Fernando and Josh. Michael, good to see you. How are things?
Things are good, Josh. I think we're both pretty cold, and I, for one, am feeling very underdressed, especially compared to our guest, who I'm sure you'll mention in a moment, was, and probably still is, a literal model.
Yeah, he's a literal model. I mean, I feel he could be dressed in nothing, and I would still feel underdressed. But either way,
could take that in a very wrong direction.
right. So, Dr. Ned McNamee, apart from me making a fool of myself, it's good to have you back on the show. So, Ned, for those who don't remember him from his prior, was it your debut on our podcast last time? But he's gone from strength to strength. Ned, I don't know if you've had any other modeling gigs, but he's a medical oncologist who is currently doing a PhD through the prestigious University of Sydney at the Children's Medical Research Institute with the ProCan oncology team, looking at, get this, words I don't understand, advanced mass spectrometry-based proteomics in clinical oncology. Essentially, he's looking at the cell and he's looking into the heart of the cell, and he's going to tell us how to cure cancer. But before we get there, I'll give you 5 years, Ned. Ned, thank you so much. How you been?
Very good. Thank you for that lovely, warm introduction as always, Josh and Michael. Good to see you both.
And we are very excited, Ned, to have your expertise. Josh said you're getting to the heart of all of cancer, but just for tonight, I think we'll settle for the heart of lung cancer at ASCO 2025. So, I mean, it's a very open-ended question, Ned, but what was the thing in ASCO 2025 specifically with lung cancer that really grabbed you, made you excited, or were there multiple things? Was it a good year for lung cancer?
Good question. I think this year it was a pretty good year for lung cancer. I think, as we'll get into talking a little bit about, there was a good couple of updates in very difficult to treat and, as you both know, traditionally terrible outcomes with small cell lung cancer, as well as some updates to some ongoing questions with some of the perioperative and neoadjuvant treatment, which is going to become increasingly relevant to all of us, especially with the lung cancer screening program starting very soon in Australia. I think we're going to see a lot of early cancers, which is good, but we're going to need to know how to best optimize those neoadjuvant and perioperative treatments. On balance, definitely a good year for lung cancer at ASCO and some exciting treatment changing updates.
And where would you start? What was your top thing from ASCO?
I think number one is in small cell lung cancer. It's the Delphi 304 study. So this was a phase 3 study in extensive stage small cell lung cancer, and this was in second line treatment, so on progression, comparing tarlatamab with chemotherapy and chemotherapy of physician's choice. The reason I think this is such a good study is that, firstly, it's positive, so that's excellent, but it's in a really difficult cohort. So as I alluded to before, when we're thinking about upfront extensive stage small cell lung cancer, we're really talking about a median survival of 12 months, and that's a study population. So that's not a everyday population, that's a good population. And so when we're looking at recurrence afterwards, the response rates to existing standards of care have been really terribly low, and we'd probably be thinking less than 10 or even 5% for a standard of care. And at least in our practice, where I've been recently, our priority is getting those second line patients onto trials wherever possible, acknowledging that the standard chemotherapy option is not very good. So I think this study, tarlatamab, so to briefly recap, it's a bispecific T cell engager. So it's a molecule which on one end has a T cell receptor, which is that CD3, and on the other end has DLL3, which is overexpressed in small cell lung cancer, as well as a lot of other tumor types as well. And so what it's doing is that it's bringing that and engaging it with the T cell to get that tumor response, but also, as we'll talk about, getting some pretty significant immune-related toxicities as well. So to recap, this is an extensive stage small cell lung cancer. It's people who have progressed after first-line chemo and immunotherapy. They included patients who had brain metastases if these were stable, and they also included people who progressed quite quickly after their first-line treatment, which is important. So included that group that was less than 90 days of their progression from their prior chemotherapy. And then they randomized them to tarlatamab or chemotherapy. And in short, it works a whole lot better than available chemotherapy options. And the overall survival presented at ASCO, which was very exciting, showed a 12-month overall survival of 53% compared to 37%. And so that's a hazard ratio of 0.6 for this very difficult group of patients who really need all the benefit they can get, especially in that second line setting.
That's very exciting. I have one question sort of right off the bat, because I mean the ideal choice for chemo in the second line for extensive stage small cell, I mean, is very patient based, really, about how frail these people are, and they're often so frail. But was there any data on what chemotherapies were chosen? Was it CAV? Was it lurbinectedin? Or
It was really interesting. So it was a little bit region dependent. So the short answer to your question is it was lurbinectedin, topotecan, or amrubicin, just depending on whereabouts patients were treated. So amrubicin being a Japanese one, and then depending on the region, either topotecan or lurbinectedin. So it was quite I guess, a heterogeneous group in the control arm for what type of chemotherapy they got. But CAV was not one of the options for the chemotherapy provided. An interesting comparison and a good point to pick up on, and I guess acknowledging that there isn't a really clear winner even in the standard of care chemotherapy for what people prefer to do anyway.
And you mentioned some worrisome immune-mediated side effects. Can you tell us more about those? Because that's
Yeah,
always the trade-off with these sorts of treatments.
absolutely. And I think part of the reason it's worrisome is a little bit oncologists' lack of experience with some of these immune-based therapies. So we're learning from our hematology colleagues who've been dealing with things like cytokine release syndrome and ICANS with CAR T cell therapy for a long time now, and it's really very rapidly becoming a part of medical oncology and solid tumor oncology as well. And so what I was alluding to there was 56% of patients had some type of cytokine release syndrome, and 6% had an ICANS event. Admittedly, these were not high grade, but I still think it's a concerning element of the treatment and something that we need to be cognizant of and ready to manage. In terms of the higher grades, we still had reasonably high rates of serious adverse events, 17% serious cytokine release syndrome and 4% serious ICANS, including one fatality, which was attributed to ICANS. And this was presented in a little bit of there were lots of other things going on, but I think it's not to be shirked at that there was still that significant negative outcome from ICANS.
And for those listeners who are not in front of a computer like I am and can't Google what ICANS actually stands for, am I right in saying that's immune effector cell-associated neurotoxicity syndrome, Ned? That was
That's exactly
completely
right.
off the top of my head. Definitely did
Sorry,
not Google that.
no, you're exactly right, and it can be quite concerning, and it's a little bit of a tricky thing to score. As you'll both know, there's a lot of robust scoring methods and handwriting tests and different types of quizzes where we're trying to assess it quite subtly, and then deciding when to intervene can be quite tricky as well. And as I say, it's new for us medical oncologists, but it's becoming old news for CAR T cell treatments in hematology. And part of the challenge with these increased toxicities and with this immune mediated treatment is the monitoring around it. And I think that's going to be one of the biggest limitations in how we can actually get tarlatamab to our patients. In the trial, for the majority of the trial, patients required a 48-hour admission on day 1 and day 8. And during the scope of this phase 3 trial, that was reduced to an outpatient setting, 6 to 8 hours for those treatments. But that's still, even a 6 to 8 hour chair time twice per cycle is very demanding from a resource point of view. And it also goes along with a lot of upskilling of not just medical oncologists, but a lot of the chemo suite nursing staff and other clinical support staff, so that we're not missing critical toxicities.
Yeah, the shift, the paradigm shift, I think you're saying is the T cell engagers are not just in the world of lung, but also in the world of prostate with quite a
Mm,
few interesting studies. And you're right, this idea that having to monitor people and organize beds for them, it's
mm,
becoming a slightly, maybe not a dilemma for those in the private world, but in the public world, there's definitely a lot of logistics.
mm.
Uh, So eloquently put, Ned. I have no further questions of anything in the universe. But
Good.
if we move along, so that was,
Yeah.
do you feel that was the most, I guess, paradigm shifting trial that you saw in
I
ASCO this year?
I think from a lung cancer perspective, I think it's right up there, and I think it's a real confirmation of a practice change that we now need to pursue the resources and approvals and education to
Yeah.
enact. I think it is a really big shift in survival for a difficult to treat
Oh,
situation.
terribly difficult. I
Mm,
still remember, all of the atezolizumab trials. It was 2 months overall survival advantage, and yet a hazard ratio of 0.75. And I think
mm,
the Durva was hazard ratio of 0.71 in this small cell setting. And I'm just like, well, I feel like neither of these are particularly catastrophically positive in a good way.
mm,
Wrong word. But
mm.
moving on,
Mm.
what's
So
next?
yeah,
So
so I think
what's
yeah. So thinking still about that difficult small cell paradigm. The other one I wanted to mention briefly was IMFORTE, and that's looking at maintenance lurbinectedin chemotherapy with atezolizumab after that induction phase of chemo immunotherapy for extensive stage small cell lung cancer. So to briefly recap this particular study design, so patients with extensive stage small cell lung cancer, critically they tried to enrich their population for a slightly better group by excluding patients with brain metastases. And so they received their planned atezolizumab and carboplatin etoposide, which is our standard of care in Australia as well. And after that induction treatment, they were then randomized if they hadn't progressed or had other complications to either receiving ongoing atezolizumab, which is what we would do normally, or durvalumab, or to also receive lurbinectedin along with their immunotherapy. And that was essentially treatment until there was a toxicity or they progressed. And before looking at the outcomes of this trial, I think one of the challenging situations that this trial brings about is that really adds, I think, a reasonable amount of toxicity and some quality of life challenges for taking somebody who's already got quite a nasty disease, giving them intensive chemo, and then actually intensifying the maintenance phase with more chemotherapy. And so undoubtedly contributing to more lethargy, more nausea, more hematological toxicity as well, in addition to the atezolizumab. But having said that, it is a difficult to treat disease, and this was also a positive study. So, another positive phase 3 study, which increased the 12-month overall survival at that landmark from 44% to 56%. So, I think definitely a reasonable increase in survival with that treatment. But exactly as you alluded to, Josh, earlier, still very much a trade off with what we're willing to suggest to patients and what patients are willing to put up with for those benefits.
Yeah, it's interesting, Ned. I'm just having a look at some of the data, and whilst you're right that toxicity, you can't really hide when you double the toxicity adverse event
That's
cycle.
exactly right.
But the AE, like discontinuation to an adverse event, was only about 3%. So like a
Hmm.
really interesting. I don't know, just for someone where you've got grade 3 adverse events and a 5 times limit, but the discontinue rate has only doubled. It's sort of I feel that's sort of a bit of a grey area for this particular trial.
I think that's right, and I think it's. I haven't seen it. It may exist already, but I think I'd be very interested to see some of the patient-reported outcomes as well.
Yeah.
I think that's a really good way to assess exactly what you're describing, which is what people are willing to put up with to get those benefits.
Yeah. And so let's move on. What is about some of the maybe the early
Yeah,
phase trials?
Yeah, exactly. So, thinking about some of the, well, I guess some of the earlier line trials which I was looking at were things like the resectable lung cancers. And so
Oh,
we had
yes,
some really,
please.
yeah, that's right. And so much more exciting when we talk about increasing the rates of cure and increasing the rates of PathCR. And I think the key one to talk about in this setting is Checkmate 816. And this is not a study that we've heard nothing about. We've had lots of updates over the past few years about Checkmate 816. And to recap, that's a resectable lung cancer population without oncogenic drivers, as in genetic drivers. And patients were receiving 3 cycles of chemotherapy alone or nivolumab plus chemotherapy prior to their lung cancer resection. And we heard previously that there was a very big increase in the PathCR rate. So the complete response rate was 24% in the immunotherapy group compared to just 2% in the chemotherapy group. And the big update we got this year, which I think confirms it as a very serious option for these patients is the overall survival numbers. And we saw the 5-year overall survival of the immunotherapy group being 65% compared to 55% in the chemotherapy alone group. And so I think that confirms for us that with just 3 cycles of immunotherapy plus chemo beforehand, we're getting a really dramatic increase in both the path-CR rate and now the 5-year overall survival. And some of the really exciting things that came out of this was the analysis of overall survival by path-CR, and that was something we hadn't seen before. And we essentially saw that in the nivolumab group, if you had a path-CR, you had a 95% 5-year overall survival compared to 56% if you did not have a path-CR. And that really helped some of those conversations in the clinic around lung cancer because we didn't have some of that data, which was what does a really good neoadjuvant response actually mean in the long term? We've had it before a little bit in breast cancer. We've had the RCB classes for quite a while, and we've been able to interpret that. But now in lung cancer, especially in the context of neoadjuvant immunotherapy, that's a new conversation that we're going to need to start having, and that's a really helpful data point to say that a PAT-CR is a really good result, and we can relax quite a lot, I think, once we get that result.
Yeah, it's a really impressive study, and it's nice to see it carried to its conclusion, especially because this is a study that didn't just enroll stage ones, Ned, which are frequently cured by surgery alone. I mean, we know that adjuvant chemo barely adds anything, but they're including patients all the way up to stage 3A. So these are very nasty, nasty cancers that probably more often than not would recur. So that's great. I think another thing that I had heard about was some exploratory analysis in patients with ctDNA, which is something else that is sort of like immunotherapy and targeted therapy beforehand, but just becoming ubiquitous across tumor types. It's obviously getting a lot of press in bowel and some in prostate, I think, as well. But here we see it in lung.
You're exactly right. And I completely agree with you. ctDNA as a biomarker across tumors is increasingly relevant. And again, issues about access and how we interpret it are becoming really interesting. In the setting of Checkmate 816, they did a ctDNA prior to surgery, so after the 3 cycles of neoadjuvant treatment. And if the patients had cleared their ctDNA, meaning they were unable to detect any circulating tumor DNA after the treatment, they had a 75% 5-year overall survival compared to just 53% if they hadn't managed to clear that ctDNA. And how we use that information, and do we identify patients that need more intensive treatment, or do we identify patients who we don't need to push as hard, I think remains a little bit unclear, but a very interesting prognostic marker.
And it's important also to note with this study is that this is not just for adenocarcinomas, which obviously make up the majority of non-small cell. They included squamous as well, which stereotypically are considered a little bit worse, I guess, on average, if you're averaging out a very heterogeneous group.
I think that's right, and I think what was nice to see was when they did go through that forest plot of all the subgroups, it did look like a very much across the board type effect. I think the one that concerned me probably the most, even though the study's not powered to look for those types of differences, was in the PDL1 negative group. So that PDL1 less than 1% really didn't seem to have the benefit that was seen in the PDL1 of 1% or more. And when they put those up side by side, it's a really clear lack of effect, if you like, in the PDL1 less than 1%. But as I say, with the power of the study and not a specific question that we're trying to answer, I think it's hard to know what to do with that information. But certainly in those PDL1 positive patients, we'd be even more confident to push for this neoadjuvant immune checkpoint inhibitor approach.
Absolutely. These are all fantastic practice-changing studies, Ned. But I mean, we always have one eye on the future with these major meetings, and that's what I think is so good about them. Is we see the stuff that might not be so ready for prime time. It might be a poster hidden away in some corner there, and someone finds it and says, "Oh, this is pretty cool." Was there anything sort of basic science, early phase that you thought,
Yeah.
fills a hole or could fill a hole in the future that you thought was quite interesting?
Look, I think thinking about those things that were perhaps not quite center stage, I thought I've alluded a couple of times towards things to do with access and a little bit the economics of oncology. We know that immunotherapy especially is extremely expensive and not universally accessible in different parts of the world. Similarly with things like ctDNA. To that end, there was a really interesting study that came out of Mumbai, a phase 3 study, which was comparing ultra low dose immunotherapy with standard of care chemotherapy across multiple different tumor types. What they were doing was completely in that context of limited resources and working out if they were able to demonstrate efficacy on much lower doses, as well as with some preclinical data to suggest that perhaps we are giving more immunotherapy than we need to. They randomized patients to receive standard of care chemotherapy, predominantly in lung cancer, or low dose immunotherapy alone, a study which I think would be really hard to do in somewhere like Australia. But they gave 20 milligrams of nivolumab every 2 weeks, which for comparison, our usual 2 weekly flat dosing of nivolumab is 240 milligrams. So it's less than 10% of the dose that we would give routinely. And they demonstrated that it was a positive study, that they had a hazard ratio of 0.8, whereby even with ultra low dose immunotherapy compared to standard of care chemotherapy was still a potentially efficacious option. And in that scenario where resources are limited, it is a really interesting study and I guess supports further research towards that end of, are we giving too much immunotherapy everywhere else?
Yeah, it's the idea of giving too much of everything, isn't it? It's that maximum tolerated DLT, right? Dose limiting
Mm,
toxicity kind of
mm.
scenario. And probably, you're probably right. We probably should be giving less. There's no evidence for me to say that, but I think that's just the
Or now maybe there's a little bit of a
Maybe a little bit.
discussion point,
just
a
a
little
smidge,
bit
just a
more
smidge.
equipoise. But I think you're right. I think we're well off changing our practice, but it's an interesting, thought-provoking starting point where we might be able to use our resources a bit more wisely.
Yeah, and what do you think was the most disappointing or surprising result? So, we have a world, and I think one thing that everyone who comes on this show says, like, you're so excited the day of ASCO and ESMO. You go home, you're like, this is going to change my practice. And then you're like, hold on. Here are 316 questions I have not answered.
That's
And then,
right.
what did you find?
The Yeah, so the study, the data which raised the most questions for me was data around the time of day of delivery of immune checkpoint inhibitors. And I don't know if you've come across this yet or if anyone's spoken to you about it, but there were probably three different abstracts which all address this same question. It's been brought up before preclinically as well as with some retrospective data. The essence of the question being, if we give immunotherapy earlier in the day, is it more effective than late in the day?
Oh, yeah,
And
this was a
this
great trial.
That's right. And this year at ASCO, we had the first randomized trial which addressed this question. Everything else previously had been retrospective. And so there was a group that did their research in China, which randomized to giving immunotherapy in advanced non-small lung cancer either before or after 3 p.m. And they used that 3 p.m. cutoff based on that retrospective data where they were trying to see where the most significant line in the sand would be. And they demonstrated both a positive PFS and OS benefit of immunotherapy earlier in the day. And the reason I bring this up as being the most surprising is because despite the fact that I understand there may be some diurnal and circadian variation in T cell activity at different times of the day, but I struggle to wrap my head around how immunotherapy with a half-life of about 1 month can have such dramatic differences for when you receive the immunotherapy in your body. It's still there the next morning and the next morning, but despite that, this study was positive with an OS hazard ratio of 0.45 with a significant benefit of receiving immunotherapy earlier in the day.
That is fascinating, and it's one of those studies, Ned, that I think poses more questions than it
Mm,
solves. And most of those questions begin with why or
mm,
what the hell is going on. Because, I mean, my first thought was exactly what you said, the sort of diurnal, I mean, you see it in the cortisol
mm,
spikes, and there's almost certainly something to do with that. But to have a hazard ratio of 0.45 for overall survival, I'm assuming that one study didn't all have PD-L1s of 100% and one arm had PD-L1s of 0%. But it's really fascinating, and it'll be very interesting to see if all of the other studies looking at this bear out similar results, or if it just muddies the waters, and B, all of that post hoc stuff as to that tries to tease out why.
I think that's right, and I'm excited about the possibility the possibility for treatment personalization based on time. There's a French group, I think, who is looking at based on measuring your immune cell activity at different times of day, and then adjusting when they give the immunotherapy based on that might be the cheapest way we've improved immunotherapy ever, just by figuring out what time of day each person should be receiving it.
Yeah, I was reading a book. This is completely irrelevant. I was reading a book, and something stuck with me, where one person says the problem with clever people is they think solutions to problems always have to be clever, and I think we're seeing that fallacy in action here. That'd be fantastic. Although I will say, all of the poor people who are responsible for booking patients probably heard this and then just curled up and cried, having to shovel the immunotherapy patients before 3 p.m.
That's right. I was thinking about that. Maybe everyone who's on chemo you do in the afternoon. I don't know what the answer would be to the chair time management.
Exactly. I mean, again, more questions than answers. Ned, were there any honourable mentions before we wrap up? You're a busy man who's trying to solve all of cancer in an afternoon.
Right.
But were there any honourable mentions that you just could not leave without at least giving a shout out?
I just want to give two quick honourable mentions. So very, very briefly, NeoADAURA was looking at neoadjuvant osimertinib for resectable lung cancer. And the short answer is very interesting, but we don't know what to do with it yet because we've got amazing adjuvant data for osimertinib. And is it worth risking even the very low risk of having a poor response and missing out on surgery for those people? So NeoADAURA, I think, we will wait and see what the more mature data looks like. And the second one I wanted to quickly mention was on the theme of biomarkers. Tropion Lung 02 did some very clever work with their biomarker. So I just wanted to quickly mention they came up with what's called a QCS NMR, which is a normalized membrane ratio, which is where they digitized immunohistochemical slide. And then with the powers of AI and modern technology, they assessed the target expression in the cell and on the outside of the cell and used that ratio to see if they could predict who responds better. And the short answer is they could. So by having a more subtle combination of existing IHC technology and digital analysis, they could improve the performance of their biomarker to better predict who's going to respond to their Dato-DXd drug. And I thought that was fascinating. That was an expansion of existing technology to have much better performance.
Yeah, that's really quite. It's an interesting. Yeah, you're touching on all of these things that, while at the moment they're not kind of prime time, but it's what you need. It's like you need the biomarker. There was another. I don't know if it was an ASCO, but it was released in the last couple of weeks that I think Roche, one of the other big companies, is looking at like building a drug that actually works inside the cell, as in it's not kind of delivered to the cell, but it sort of starts within the cell. I didn't really get it. It wasn't like, I think it was in Nature somewhere, but I'm like, oh yeah, rather than delivering it to the cell, if you do it intrinsically. But really, really cool stuff, and this big data is really coming to it. But Ned, this has been a wonderful, wonderful little ASCO episode. You've been brilliant as always. I cannot commend you enough. I just don't think you ever need to go back to modeling. I think that's the summary of today. But thank you again.
Man's got to eat, Josh. Man's got to eat.
That's it. Thank you for being on the show. We've all learned a lot. And guys, don't forget to like and subscribe if you love what Ned did. But like this podcast also, unless you have a catalog you need to let us know about.
Thank you, Josh. Thank you, Michael. Always nice to come and talk about some updates. I think some exciting stuff.
Yeah, brilliant. And we'll probably see you at ESMO.
That's right.
Looking forward to it.
Bye, everyone.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer,
Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.